Hi guys, good morning. So today we are going to discuss our next topic, that is the anchorage. So basically the anchorage, it is the site of a delivery from which the force is exerted. See, let's take an example that what is anchorage. A patient comes to you, you have planned the upper premolar extraction. So what is the aim of extracting these premolar? You want to retract these 6 teeth, 1 2 3 4 5 6. These 6 teeth you want to retract into the extraction space. You want the retraction of these teeth into the extraction space so that there you can decrease the overjet. Now what is anchorage? Anchorage means that you want only the retraction of these 6 teeth. You don't want the protraction. It means you don't want the mesial movement of these teeth into the extraction space. So this is what anchorage is. So the appliances, there are various appliances which are used to hold these teeth in to their original position, and they does not cause any kind of mesial movement of the molars. Fine. So the molar are the one which are basically used to provide the anchorage. Fine. So your main aim is to retract these 6 teeth into the extraction space, but you don't want that your molar to be moved mesially. So in that case you will use a number of appliances like this. This is an Nance palatal arch. This is the button, acrylic button. So what you have to do, solder this appliance with the molar. So this appliance, it will restrict the molar into its of the molar. It does not allow the mesial movement of the molar. So this is what anchorage is. Sources of the anchorage, these are of two types. We have the intraoral sources and we have the extraoral sources. So the intraoral sources, in this we have the teeth, alveolar bone, basal jaw bone and the musculature, while in the extraoral, basically these are the headgears. Like we use the headgear in the cranium, that is the occipital headgear, and the back of the neck, that is the cervical, which provide the cervical anchorage, that is the cervical headgear, and we also take the anchorage from the facial bone. Now we are going to discuss the intraoral sources first. So in this, first are the teeth. See, we have 3 types of cross section of the root. Number 1, we have the round, we have flat, third is triangular. Fine. Important point is the triangular roots of the canine and the maxillary and central, maxillary central and maxillary lateral incisor. These offer the maximum anchorage. So in this, the triangular anchorage, these provide more resistance, or these provide more anchorage than that of the round and flat roots. MCQ. I'm repeating it again. The triangular roots, they provide maximum anchorage than that of the round and the flat roots. Right? Second is the size and the number of the roots. So important point is the multi-rooted teeth having a large root, they provide greater anchorage, or they provide maximum anchorage. So the multi-rooted teeth, they provide the maximum anchorage. Next is the root length. See, in this, longer is the root, it is more deeply embedded in the bone, it provides maximum or more anchorage. Fourth are the ankylosed teeth. See, the ankylosed teeth, these are directly fixed to the alveolar bone because they do not have periodontal ligament. Therefore, these are the ankylosed teeth, these are the excellent these are act as an excellent anchors, or these provide the excellent anchorage. Next are the dilacerated root. These are often provide the greater resistance, therefore they are good anchors. Fine. I'm repeating it again because all the 5 points, these are very important for your MCQ point of view. In the root form, the triangular root, it provides the maximum anchorage. The multi-rooted teeth, they are which are having the large root, they provide the greater anchorage. Longer is the root, deeply embedded it is in the bone, and they provide more anchorage. And Ankylosed tooth, these are the excellent anchors, while the dilacerated root, these are also provide the good anchorage. So this is all about the teeth. Second is the alveolar bone. So the alveolar bone, it is also a good anchor, or it also act as a good anchor. And third one is the basal jaw bone. So it is, these are the intraoral hard areas of the basal bone which are used to augment the intramaxillary and intermaxillary anchorage. So the basal jaw bone, it is also provide the intra as well as the intermaxillary anchorage. Next is the musculature. So the musculature is mostly commonly asked MCQ first of all. So in this, the dental anchorage, it may be increased by use of hypertonic labial musculature, as in case of lip bumper. Commonly asked MCQ, the lip bumper. Fine. So after the intraoral anchorage, coming on to the extraoral sources of the anchorage. First is the cranium. So in this, the extraoral anchorage, it can be used by headgear. And the headgears, these are derived the anchorage from the occipital area as well as from the cranium or from the parietal region. Second are the back of the neck. So in this, the extraoral anchorage, these can be obtained from the back of the neck, and this type of headgear, these are called as the cervical headgear. Third one are the facial bones. So these are the facial bones and the mandibular symphysis. These are often provide as a maximum anchorage. Fine. So these are the intraoral and the extraoral sources, very important for your MCQ point of view. So before discussing the types of the anchorage, let's discuss the classification first, which was given by Moyers. So according to the manner of force of application, we have the simple anchorage, we have the stationary, and we have the reciprocal anchorage. According to the jaw involved, we have the intramaxillary, it means single jaw, intermaxillary, both the jaws involved. According to the site of anchorage, the intraoral, extraoral, these are the headgears, the cervical, occipital, cranial, and the facial musculature or the facial bone. In the musculature, we have the lip bumper. According to the number of anchorage unit, we have the single or the primary anchorage. We have the compound anchorage. It means single means one tooth, compound means more than two teeth, and multiple or reinforced anchorage. Fine. Starting with the first, that is the simple anchorage. So simple anchorage, it is resist to tipping. MCQ. Fine. So the simple anchorage, in which the manner and the application of the force, it is in such a way that it tends to change the axial inclination. Again, MCQ. So in the simple anchorage, it is the one in which the manner and the application of the force is such a way that it tends to change the axial inclination of the tooth. Very important. So if a question comes, which of the following anchorage is tend to change the axial inclination, so your answer should be simple anchorage. Like this is the example. So in this, this is the acrylic plate, and this is the screw which is incorporating into the acrylic plate, and it is mainly used for the buccal movement of the premolar. The premolar, it is palatally placed. This screw, it helps to push the premolar buccally. Fine. So second is the stationary anchorage. So it is resistant to bodily movement. Fine. Examples are the headgears. Important. So after this, very important anchorage is the reciprocal anchorage. Commonly asked MCQs from the reciprocal anchorage. So what is reciprocal anchorage? So in this, the teeth may be pulled towards each other to close the space. Let's take an example of the midline. See, this is a midline space. Fine. This is in a fixed ortho, and this is in a removable ortho. Fine. Let's talk about the fixed ortho first. So in this, you have placed the bracket. Now you have to close this midline space. So what you have to do is, you just apply the pressure, or you just apply the force apply the force of equal magnitude but opposite in direction. For example, these are the maxillary central incisor, and this is the space which you want to close. So what you have to do is, you will apply the same amount of force, either through EJ from elastomeric chain. Fine. So in this, you have to apply the same amount of force but in different directions to close this space. Fine. So this is, we use the E chain or the elastomeric chain in a fixed ortho. Second is about the removable ortho. So in this is the acrylic plate, and these are the finger springs like this. These are the finger spring. Fine. So these are incorporated in a acrylic plate. So the function of these two finger spring is to bring these two central incisor together to close this space. Now third are the elastic. This is the crossbite elastic for the correction of a single tooth crossbite, that is the posterior crossbite. Right? So, and fourth one is your removable. This you can, again, the crossbite is or your crossbite elastic or the cross elastic you can use in the fixed ortho, while this is the omega shaped coffin spring. Coffin spring. It was given by Walter. Coffin. That is why it is called as coffin spring. So it is used to expand the arch. Therefore, it is used for the expansion. So in the same way, the force is applied in the same amount of force but applied in different direction. Fine. So example of the reciprocal anchorage are in case of midline diastema, in case of crossed elastics, in case of expansion. Very important. Midline diastema. So the reciprocal anchorage is used in case of midline diastema, number 1. Number 2 in crossbite, to correct the crossbite, and number 3 is for the expansion. MCQs. Right? So according, next classification, second part of the classification is according to the site of the anchorage. So in this we have an intraoral, we have extraoral, we have a muscular. We have already discussed about the teeth, palate, the lingual alveolar bone of the mandible. Extraoral about the headgear and the facial bone. Muscular about the lip bumper, we have already discussed. So third is according to the jaws involved. So in this we have the intramaxillary anchorage, we have the intermaxillary anchorage. The intramaxillary anchorage means offering all the units offering the resistance which are situated in a same jaw, and it is called intramaxillary anchorage. Intermaxillary anchorage when both the jaws are involved. When both the jaws are involved, these are called as intermaxillary. So first we are going to discuss about the intramaxillary anchorage. In this, all the units which are offering the resistance, these are situated in a same jaw. Fine. For example, the TPA, that is the transpalatal arch, the lingual arch, Nance palatal arch, modified Nance button, and utility arch. So we are going to discuss them one by one. First is the TPA. It means the transpalatal arch, given in maxilla or given in maxillary arch. Right. So this is canine, your incisors, right, and this is your molar. So TPA is like this. These are your molar. TPA is like this. Fine. So the TPA, it is made up of stainless steel wire and it is cemented onto the molar. Either it is soldered or it is engages in the lingual sheath. This is a lingual sheath. It has a passage for the insertion of the TPA arm. Fine. So on the buccal side there is a molar tube, and on the lingual side you need to weld the lingual sheath for the insertion of your TPA. Fine. So the TPA, it was given by Robert A. Goshgarian, number 1. Fine. And it is also used for the TPA, it is also used for the molar distalization. Second, it is also provide the anchorage. It means it does not allow the mesial movement of the molar. This is what the anchorage is. So it provides the anchorage. Also it is used for the molar stabilization and also used for torquing the root of the molars. Fine. So this is what TPA is. It is given in your maxillary arch. Now second is the lingual arch. Second is lingual arch. So the lingual arch, it is given in the mandibular arch. These are your molars, these are your anteriors. Right? So your lingual arch is like this. Right? It is either soldered onto the mandibular molar, or again you weld the lingual sheath. Right? So it is the U-shaped arm which touches the cingulum of the lower anterior. Right? So the lingual arch, it is given in the mandibular arch and it is mainly used for the anchorage purpose. It does not allow the mesial movement of the mandibular molar into the extraction space. Right? Third are your Nance palatal arch. So this is your Nance palatal arch. See. So the Nance palatal arch, I am writing over here the important point regarding this. The Nance palatal arch, it is used in the upper arch and it is used during the leveling and aligning and during the canine retraction, fine. And it is also used in case of molar distalization, distal movement of the molar, fine. And it is also very important point, the Nance palatal arch, it is also act as a, or it is also used as a space maintainer, right? This is the button which is called as acrylic button, right? So this is the Nance palatal arch. And next, last is the utility arch. So the utility arch, it is given by rickets, first of all, important, fine. And it is also used as a space maintainer in case of mixed dentition. It is inserted in the molar tubes, fine. And it also provides the anchorage. So this is all about the intramaxillary anchorage. Now next are the intermaxillary anchorage, commonly asked MCQ, Baker's anchorage. Your intermaxillary, please note it down, not the intra, the intermaxillary anchorage, it is also called as Baker's anchorage. So in this, the resistance unit, these are situated in one jaw, and these are used to affect the tooth movement in the opposing jaw. See, I'm writing here about the intermaxillary or about the Baker's anchorage. First are the class 2 elastics. First are the class 2 elastics. So in this, what you want is, you want in class 2 cases, already there is proclination of the upper incisor. So what you want is, you want the retraction of the upper teeth from canine to canine, right? So in this way, the elastic, it is placed, this is the canine, right? And this is your mandibular molar, right? This is the buccal tube and this is the bracket. So class 2 elastic is, you place an elastic from the upper canine to the lower first molar, from the maxillary canine to the lower first molar. In this way, the elastic, it helps in distal movement of the canine or to retract the canine, fine. Second is class 3 elastic, just opposite of class 2 elastic. In this, it is the maxillary first molar, this is the maxillary first molar, this is the buccal tube, and this is your mandibular canine, this is the bracket. So the elastic, it passes from the upper first maxillary molar to lower canine. So this is what class 3 elastic. In this, in class 3 elastic, what want to achieve is, you want the retraction of the lower incisor, it means the distal movement of the lower teeth, and protraction, that means the mesial movement of the upper teeth, fine. So in class 2 elastic, from the upper canine to the first mandibular molar, and in class 3 from the upper first maxillary molar to the mandibular canine. It is, don't get confused, class 2 and class 3. The basic purpose of class 2 is to retract the maxillary anteriors, and in class 3 retract the mandibular anterior and protract or mesial movement of the posterior or the molars, fine. And yes, these two, the class 2 and class 3, these are not the anchorage saber. Why? Because in class 2 there is a mesial movement of, little mesial movement of the mandibular molar, while in class 3 there is mesial movement of the maxillary molar. So in this, the anchorage is lost, so therefore it is also called as non-anchorage saver. Important for your MCQ. Class 2 elastic and class 3 elastic, these are not the anchorage saver. Why? Because in these two there will be anchorage loss, or there will be loss of anchorage. Fine. So third are the box elastic. Yes, box elastic. So the box elastic, we are usually use these kind of elastic in case of open bite. See, this is your maxillary canine, these are your mandibular canine. This space is open. Fine. So you place these are your brackets. So you place the elastic in a box pattern, only one elastic. You need to engage the one elastic on all the 4 canine. So this is the box elastic. It is used to correct the open bite. Right. Fourth one are the diagonal elastics. So the diagonal elastics, these are the elastics which are used to treat or which are used to correct the midline. Right. For example, this is your midline. So this is your maxillary incisor, and this is your mandibular incisor, and this is your midline, and your maxillary is shifted toward the left side, and your mandibular midline, it is shifted toward the right side. Right. So in that case you need to give the elastic in a diagonal fashion. From this canine, this is canine, this is canine, from this canine to this canine, in this way. These are called as diagonal elastics. Fine. So this is all about the intermaxillary anchorage. So fourth one and the last one in the classification is according to the number of the anchorage unit. So single or the primary anchorage, as the name suggests, in this the single tooth with a greater alveolar support, it is used to move the another tooth with less support. Fine. Compound means more than 2. So in this the resistance is provided by more than one tooth with a greater support, which is used to move the teeth with the lesser support. Fine. Third one, reinforced, very important. So in reinforced, in which more than one type of resistance units is utilized. This is what we called as reinforced anchorage. So in this, first is the external anchorage. In this we use the headgear, we use the cervical headgear, we use the occipital headgears. Fine. And second most important commonly asked MCQ are the upper anterior inclined plane. See, this is your maxillary central incisor. Fine. So in this there is an inclined plane. This is the inclined plane which is used mostly in the upper arch. So in this, a removable appliance which is incorporating a inclined plane, it results in the forward movement of the mandible during the closure of the mouth or the closure of the jaw. Therefore it results in the important stretching of the retractor muscles of mandible. Fine. So in this, when you give the inclined plane, it helps in the forward movement or the mandibular forward closure of the mandible. Therefore it leads to the stretching of the retractor muscle of the mandible. Fine. Now what is SEVED? SVED, SEVED appliance, modification of an anterior inclined plane. It is a SEVED appliance. It means it has a, this is the inclined plane, and civil inclined plane is this is civil appliance is the modification of the inclined plane. C. This is the inclined plane and this is the civil plane. It means there is an additional upper incisal capping. In a normal or simple inclined plane, there is no capping, while in the inclined plane or in the civet appliance, there will be additional upper incisal capping. This is the basic difference and it is commonly asked MCQ. Fine. So next are the Nance-Palter arch. We have already discussed. Utility arch given by Ricketts we have already discussed. So after this, next are the TAD, that means the temporary anchorage device. So in the TAD we usually use the implants or the mini implants. Why it is called as the temporary anchorage device? Because the mini implants which we are using in ortho, it is not permanent. We are using the implants only for the anchorage purpose, and the implants, very important, they provide the absolute anchorage. Very important, absolute anchorage. The implant, they does not allow the mesial movement of the molars. It means they provide the 100% or the absolute anchorage. So our basic purpose of using the implants is to provide the anchorage when all the 6 anteriors get retracted and close the extracted space. We just remove the implants. That is why we called it as a temporary anchorage device. When we achieve the total retraction of all the 6 teeth into the first premolar space, we'll remove the implants. Right? So the implants or the mini implants, these are used in case of Bimax. Bimax cases are the cases in which there is proclination of upper as well as the lower incisors. The implants, the mini implants, these are also used for the distalization of the molar in case of anterior open bite, in case of deep bite, in case of intrusion of the maxillary teeth. Fine. So the size is, first of all, we use the titanium implants or the titanium alloy mini implants because these are titanium, it is biocompatible. Due to its biocompatibility, we use the mini implants. So the width we use is about 1.2 to 2 mm. The length is usually ranges from 6 to 12 mm in length, but for the maxillary arch we use the 7 to 8 mm, and in the mandibular arch we use 5 to 6 mm long. Now after this, coming on to the placement of the implant. So in the maxillary arch, the implant, it is placed 30 to 40 degree to the long axis of the maxillary teeth, while in the mandibular arch, the mini implants, these are to be placed at the angle of 20 to 60 degree to the long axis of the mandibular teeth. Fine. These 2 points are very important for your MCQ. See, the loss of anchorage, it is also called as slipped anchorage, burning anchorage and clown anchorage. These 3 terminologies, these are used for the loss of anchorage. Now after this, coming on to the maximum anchorage. So the maximum anchorage is provided by the maxillary first molar, then by the mandibular first molar, then by the mandibular second molar, and lastly by the maxillary canine. Very important, commonly asked MCQ. The maximum anchorage is provided by maxillary first molar, next is by the mandibular first molar, then is by the mandibular second molar, and at the last by the maxillary canine due to its long root. Right? Lastly, the classification See, in this we have the maximum anchorage, we have the moderate anchorage, and we have the minimum anchorage. I'm just drawing a diagram. In this, let's talk about the maximum anchorage first. So the maximum anchorage in this, it is also called as type A anchorage, right? So in this, your main aim is to bring back the anterior 6 into the extracted space, but in case of maximum anchorage, there will be 75% retraction of the maxillary or of the anterior teeth, and 25% protraction, it means the mesial movement of the posterior teeth. Fine. So in the maximum anchorage, 75% your anteriors will move into the extracted space, and 25% there will be mesial movement of the posterior teeth. So this is what we call as the maximum anchorage. And in the moderate anchorage, there will be 50%, 50-50. It means 50% anteriors will retract and 50% posterior will protract. While in the minimum anchorage, the opposite of the maximum anchorage. In this, 75% the posterior will protract and 25% the anterior will retract. Right? So this is the type A, this is type B, and type C. This is your maximum anchorage, moderate anchorage, and minimum anchorage. 75 retraction, 25% mesial migration, that is the protraction of the posterior. In this, 50% retraction, 50% protraction. In minimum, your 75% protraction of the or the mesial movement of the posterior, 25% retraction, it means distal movement of the anteriors. Fine. So guys, this is all about the anchorage, important topic. Please go through it once and try to make the notes. Thank you.